pray you hear. Professor Winston Davidson, Professor Mavreed, Dr. Davy, specially invited guests, colleagues, friends, ladies and gentlemen. I am Dr. Seni Ononoju, current chair of the Caribbean College of Family Physicians Jamaican chapter. I bring you greetings. We have with us this evening Professor Winston Davidson as our main presenter, who will speak to us on telemedicine. Telecommunication technology started in the late 19th century when Alexander Graham Bell patented the telephone in 1876 and Hyman Rudolph performed the first radio transmission in 1887. It was not until the 20th century that the general population started the use of the technology and could be applied to the field of medicine in 1925. Over the years, telemedicine grew slowly initially, and today it is widely used in the United States and other parts of the world. In Jamaica, Professor Winston Davidson has been working assiduously on the use and need of telemedicine locally in quite a number of hospitals and clinics, and also in presentations of symposia. Since the ending of 2019 with COVID-19 ravaging the world, it became necessary to use online communications. This need hastened and ushered telecommunication into the scene. On the other hand, the Caribbean College of Family Physicians, since its inception in 1987, has always appreciated the chance to encourage the seeds of knowledge and enhance the growth and development of our doctors drawn from all over the Caribbean. The aim is to improve the health status of the Caribbean people by providing the highest standards of patient care through research, information sharing, and the availability of well-trained physicians. It is also committed to patient empowerment and personal responsibility for health by therapeutic education, promotion, and concept of health and wellness rather than illness and disease. The Caribbean College of Family Physicians carries out these duties by carrying out ongoing education of our doctors through CME seminars, symposia, workshops, and online meetings such as this. The works of Dr. Davidson over the years have not gone unnoticed. As such, we feel privileged to have such an esteemed speaker with a wide experience on the subject of telemedicine tonight, and we look forward to an exciting presentation and interactive discussions. On behalf of the Caribbean College of Family Physicians, I say a warm welcome and a big thank you to all who are listening and who are participating in this timely and relevant presentation. Once again, welcome and thank you. Marvin, I finished, but I don't know if you heard. Huh? You heard? Okay.
Hello, I'm seeing Marilyn Miller's computer screen on my video. Marilyn Miller, you seem to have been sharing your computer screen. Marilyn Miller, you have your share screen on.
Good evening.
She's trying to figure out how to get the shared screen off. She's working on it.
I think she just got it off.
I took her off. I'm the host, so I can control everybody.
Okay. All right, thanks, Marvin. Thanks, Senny, for that warm welcome. I am Dr. Dane Levy, Honorary Secretary, and it is my pleasure to introduce our guest speaker this evening, Professor Winston Davidson, CD, JP, MD, BS, and PhD candidate. Dr. Winston Davidson, a public health specialist and telemedicine research pioneer, currently serves as Professor of Public Health and Health Technology and Head of the University of Technology School of Public Health and Health Technology. Professor Davidson received his medical training from the University of the West Indies during the period 1965 to 1971 and was successful in the American examination for foreign medical graduates in 1971. He also received his diploma in tropical medicine and hygiene from the Liverpool School of Tropical Medicine, University of Liverpool, England in 1975. Professor Davidson is currently a public health PhD candidate at the University of Technology School of Graduate Studies. Among his many positions held are 1996 to present, Executive Chairman of the Telemedicine Limited, 1999 to present, Chairman Health for All Jamaica Limited, 1999 to present, President and CEO, Telemedicine Diagnostic and Treatment Center, and 1997 to present, Head of the National Telemedicine Research Project, partly funded by personal funds and government grant and loan. Professor Davidson has received a number of honors and awards in recognition of his work. Among these are the Command of the Order of Distinction for Services to Medicine in 2003, and the Pearl Award for more than 30 years of distinguished and outstanding service to the people of Jamaica as Justice of the Peace in the Parish of St. Andrew in 2008. He also has to his credit more than 120 presentations, papers, and publications related to health policy planning and organizational issues, primary health care, drug abuse prevention, epidemiology, community development, public health, control of communicable diseases, environmental health, philosophy, telemedicine, information technology, and wellness. Professional affiliations include 1973 to 1976 and 2012 to present, member of the Medical Council of Jamaica. 1974 to present, member Medical Association of Jamaica. 1983 to present, founding member Association of General Practitioners. 1987 to present, member Caribbean College of Family Physicians. 1988, founding member Caribbean Public Health Association. 1995 to present, Caribbean Institute of Research and Community Development. 1998, founding member of Jamaica Public Health Doctors Association. 1998, founding member Jamaica Menopause Society, President Medical Association of Jamaica, founding member National Council for Continued Medical Education. 2001 to 2002, member of the Association of Telehealth Service Providers. 2002 to 2004, president of the Jamaica Public Health Doctors Association. 2012 to present, vice chairman of the Jamaica Anti-Doping Commission. 2012 to present, chairman of the Bureau of Standards Jamaica. And 2012 to present, chairman of the Council for Professions Supplementary to Medicine. Professor Davidson is married to Dr. Sonia Davidson, Nee Lambi, and has three daughters, Dr. Tamu Davidson, Dr. Chima Davidson, and Donna Davidson. Please help me to welcome Professor Winston Davidson now to give us his presentation on telemedicine.
Winty?
Hello, I'm trying to share my screen. Hello?
You can go ahead and share your screen, Winter.
I can go ahead and share my screen?
Yes,
Okay. All right, I will, let's see. Okay, are you seeing the screen?
Yes, yes.
Okay. Okay, all right. I will now share my, hold on a minute. Let me see something here. I'm trying to get past your, okay. Are you seeing that, my screen?
Yes, man, we're seeing your screen very well. You can go ahead.
Well, I put together a few slides, right, because I think that the most important thing is not so much the slides, but the most important thing is what I call the user acceptance test. If all of you have a cell phone or an iPad or a laptop where you are, if you don't have it, take it out, because I'm going to let you do some things here at the end of this presentation, so that you can see exactly what we have done over the years and where we are going and what is in it for you. Because this exercise, believe it or not, my partner, Mr. Sanjeev Kumar, and myself have been working together for nearly 17 years on this particular technology. And as you know, technology is something that has to be updated and upgraded at every step of the way. Now, the objective of the seminar is to look briefly at the historical review. Let's see if I can get rid of this. Okay. Look briefly at the historical review of the determining role of technology in the practice of medicine. Because initially, the research question was looking at how does information and communication technology influence medicine, and what in fact ought to be done to keep the doctor abreast of this technology. And so therefore, the first thing that we all have to have some common understanding of is the historic role of technology in medicine over the years. Then we're going to look at telemedicine in the digital globalized age, and we're briefly looking at the National Telemedicine Research Project. We're looking at ethical imperatives, including rights, responsibilities, confidentiality, privacy, and professional integrity. And of course, then we are going to look at the platform. Well, it wasn't a platform then, but it will have a platform now of Doctor on Call before and after we had the launch in 2017. And of course, the models of telemedicine for a sustainable ethical medical practice. And then after we have done that, then we're going to do the practical thing of looking at the artificial intelligent bot, which is now part of the telemedicine product. Nobody has developed that. We have developed it since 2017-18, and you will see exactly how that bot can be used for your practice. And I'll explain all of that to you. The next slide, of course, looks at the whole process of healthcare delivery over the years. And of course, you know that if you look at technology, the first technological wave that had any so-called global reach was 9,000 years ago in the age of specialization. And medicine, our colleagues in that time, more or less developed out of from artisan, the butcher, the cobbler, what have you, all of so if you were born during that age and you were a doctor, you had to have some sort of artisan's specialization. The care that you used to give during that time of 9,000 years was home care. So medicine was essentially home care. The next wave, technological wave, was the Industrial Revolution, where you had massive amounts of workers on the assembly line who were sick. and they lived in hovels. And so therefore they had to bring in hospital care. They had to put in place a hospital system where they had rows and rows of beds of these sick people, treat them so that they could go back to work for maybe 20 hours a day in the factories. Then the third wave was, of course, 45 or so years ago, where we had digital computer ICT revolution, and that brought about ambulatory care. And you all know the Japanese had who pioneered that with their fiber optic, with the use of fiber optic technologies, and of course this began digital ICT, information and communication technological revolution. That wave, third wave, lasted for about 45 years, and we are now in the fourth wave, which is the age of interactive artificial intelligence, the ICT revolution. And in that connection, we have come full circle from home care 9,000 years ago, to hospital care, which is still with us, ambulatory care, and most of what the surgeons are doing now, technology is going to cause them to have ambulatory care. You see how they are coming right back to the family physicians, right into the home care. And of course, today we have what is referred to as anywhere care, or anywhere. In other words, it doesn't matter where the patient is, but the internet and artificial intelligence now completely has gotten rid of borders. So you will be able to practice from Jamaica into Africa, right? So, right, Dr. Unusual, into Nigeria. When we finish with you, you will be able to practice medicine from Jamaica into Nigeria, believe you me. Right, so therefore, we have home care, 9,000 years ago, hospital care, which is about 300 years old, ambulatory care, 45 years, home care, back over the path in the last 15 years, and the technology now with the internet and the use of technologies on that internet platform has now created today what we call telecare or artificial intelligence. Now, what is telemedicine? In 2004, at an international conference, I more or less, based on my experiences, gave a definition, and this is what I call a functional definition. Telemedicine is an information technology network of medical and allied expertise. I always feel that the doctor alone cannot do everything, and that the health team is more important than the doctor, right? But the doctor may be at the zenith of the health team, being the best trained and most skilled of all, linked together for the purpose of delivering medical care services at a distance. So essentially, telemedicine is medicine at a distance. So telemedicine is the term used for medicine at a distance. And of course, telecare is the provision of nursing and community care of a patient at a distance. Telehealth is public health services delivered at a distance to people regardless of their health status. And by telehealth, we're talking about delivery to populations and groups rather than individuals. And telematics, information and communication technologies used in carrying out health-related activities. Now, global trends. When we started the project, there was no such thing as convergence between data, voice, and video. Video was separate, voice was separate, and data was separate. And when I look back at the network operating center that was created at Seymour Park, we had to develop an interconnection between data, voice, and video. Remember, voice was usually transmitted by the old poor old telephone service with the POTS, you know, the telephone that you had that is not the analog telephone. There was no such thing as a digital telephone. You had voice separate, you had data by fax, and you have video with some sort of camera or so, but it was separate. Now, what has happened is that all of these basic and fundamental technologies were integrated into a voice, video, data carrier technology, becoming ubiquitous. And this is the main revolution, where all of these technologies were converged that gave now the end user technology, that is the doctor, etc., the capacity to be multifunctional. In other words, to use instruments and technologies that in fact converge voice, video, and data. And the cell phone is the most important tool for that. Now, the fact is that in so doing, and this is the theory of the 4 stages theory of prevention, you will see that in relation to the whole primary, where we function, that is, we function at as family physicians at both the pre-primary level and the primary level. We are, because we function in order to maintain wellness and to build a healthy lifestyle and the capacity and resilience, wellness, resilience, etc. We are the ones who in fact deal with not only maintaining a state of health, but also mitigation of risks, and also the treatment to prevent the incidents, new cases from happening. And of course, also we're treating persons who are in chronic disease and therefore prevalence of disease. But we are not hospital-based. We are non-hospital-based. So therefore we are based primarily in communities. And this is where, as the first line of port of call for the practice of medicine, telemedicine in fact began. Because we used to use the old dial-up telephone to communicate with patients. Then we used to send fax. And now we have an internet platform where we can see patients who now use their cell phone, and we can see them directly anywhere in the world, and we can treat them. Hello? Hello?
Oh dear. Oh dear, did this thing come off?
Can you hear me? Hello? Hello?
Yes, Windsor, we can hear you. Go ahead.
Okay, so this particular slide, and you can get all the slides, will show you exactly how this, right? I have another slide which shows you how you can see patients in hotels in Jamaica and elsewhere throughout the world, and you can see them, and I'll show you exactly what we have done. Now, these slides are just a group of slides which I put together because I really want you to begin to look at the product itself. That is the doctor on call product itself, and to see exactly what we have done in that respect. Now, we had a launch in 2017, and that launch trained about 65 doctors. In 2017, we had to pause with that launch, pause with that training program and that outreach program, because we had a problem with the system paying the doctor through the banking system. We started off paying the doctor through PayPal, and then PayPal started to take 90 days to pay the doctor. And if there's one thing that your colleague would never countenance, is the doctor doing his work and can't get paid. Now, the model of telemedicine that we have then was that the doctor came on the platform, in other words, doctor on call platform, and became part of a pool of doctors. And the patients would then come and look at this pool of doctors and decide on which doctor to choose. Now, that model is a model that had its time, but it's not a proper model, as far as I'm concerned, for the Jamaican doctor. Now, while we pause with that model, we continue our experimentation or development, and we have developed what is called an artificial intelligent bot, that is a robot, that would be able to interview patients, and while at the same time that it interviews the patient, it comes up with a pre-diagnosis. Now let me give you some idea as to what this artificial intelligent bot is, because it is part of the telemedicine product that is now available to every single doctor, will be available in 3 months, at the end of 3 months, to every single doctor free of charge. And I'll tell you why it has to be free of charge. It has to be free of charge, first of all, because I'm a doctor. And there is, part of our integrity is that we must never do what is referred to as fee splitting. And so therefore, there will be no fee splitting on this platform. But I'll explain to you what it is. Each doctor will have what is known as a portal, his own system, where he puts all his patients on his system. And so he registers, and you can see there, on doctor on call, using his name. And when he gives that patient that name, and when the patient puts in that, what you call URL, they go exactly to that doctor's portal. In other words, that doctor's practice. And every patient that goes there, he can put all his patients in his practice. Nobody can get in his portal. He has full control of his patient, full control of every single thing. And all Doctor on Call does is produce the platform. What this does is gives every doctor control over his practice, and he also has control over his files. We think, my partner and I think that this is an important development. And so you will not be in a pool of doctors working on Doctor on Call. You will have your own portal. And this portal will have not only the most modern telemedicine platform, but also have artificial intelligence. In other words, it will have a bot. So what then would the researchers, myself and Sanjeev Kumar, be responsible for? We would be responsible for providing the upgrades to keep the Jamaican doctor abreast with all that is taking place internationally. Right now, you are ahead of the game because nobody has an artificial intelligence bot that's integrated into telemedicine. The reason why we are doing it is because we have been doing it for the longest while. We're going now about 17 years now, or 18 years. And we know every nook and cranny of this. And that is why we feel that once the Jamaican doctor gets this technology, he will be able to compete globally. Now, why I say able to compete globally? As you all know, I'm very sort of very passionate about the global value chain. And if we are to, as a Jamaican, if we as Jamaican are to succeed, we have to be competitive in the global system. And that is one of the reasons why, over the years, we have sought, or during all of these things that you're seeing that your colleague has been doing, from primary care to the National Health Fund, and you know that the National Health Fund was a major struggle, but we were able to overcome this. The paper that was written for the National Health Fund is still in the Medical Association of Jamaica archives, because we had to battle to get the National Health Fund against a group who wanted a national health insurance plan. And you know, from we get the national health insurance plan, the private sector is going to control medicine. Before that, we had to battle with the HMOs. I'm not sure if Dr. Aldith Buckland is there, but she knows of that particular struggle. And so therefore, we also have to understand that because we are at the cutting edge of technology, and because it's going to be free to doctors, we have no excuse. I can go to my grave to know that we have no excuse, doctors, to be at the cutting edge. We are per capita, our cost per capita is one of the lowest in the Western Hemisphere, and our quality is one of the highest. So if you have the lowest cost per capita, and you have the highest quality, and you have the technology that doesn't charge you, it means that the medical profession can be globally competitive. And if you are not, other doctors from elsewhere will see your patients and you will be marginalized. I can promise you that. If you look, I don't want to go over the whole history of the development of medicine, but you see it happening. Our last struggle that we did about 2 months ago, or 2.5 months ago, was to preserve the integrity of making our prescriptions, or saving our prescriptive rights. Because there were many forces who wanted to give away our prescriptive rights to nurse practitioners, and also prescriptive rights to other members of our team. But this did not happen, because we persevered for over 15 years of back and forth. And the last time was the last straw. And so you must understand that if we as a profession continue to maintain a level of total complacency, you will be marginalized. We see what is happening in the United States to our colleagues there, where they literally work for insurance companies. And so this gives us a level of independence where we work with insurance companies, not for insurance companies. And if our costs will be the lowest because we use this technology, then the bottom line of the insurance companies is going to be better than insurance companies abroad. So therefore, they have to work with us. Now, why is our technology much cheaper? It's cheaper because we planned the strategy of always choosing the best technology, a mix of the best technology, and with a strategic objective. Our technology has always been web-based. So you don't have to buy anybody's equipment to practice telemedicine. You use your browser, and you use your web portal. In other words, you put up your website, you have your portal, and you see your patients, and you can see any patient anywhere in the world. And you see them using voice video, a converged platform of video conferencing. And the patient can see you using either his cell phone, his computer, laptop, or his iPad, and you can do the same. And so, this new system that we are putting in place, and will be ready in 3 months, incidentally, the DocBot, the robot, the artificial intelligence, it is up and running, and this is not a triad system. This is not an algorithm. This is a genuine, intelligent robot that is learning. At the back end of this robot are all the diseases of the International Code of Diseases, ICD-10 codes, massive database. And we have superseded, in other words, put on top of that database, integrated in that database, the latest WHO algorithm for COVID-19, which means that it can do a screening and pre-diagnosis of COVID-19, while at the same time do also the screening of a patient if they have chronic disease. And so let us now move to, and I'm going to now look at the next slide. And if you have a cell phone or what have you, you can then get this link. You see the link there, droncalljamaica.com, and I'll go through that platform to show you what it is, but we have suspended it because it's being upgraded now, and it's going to take 3 months to upgrade it. But you can, in fact, test the bot. I always believe in user acceptance tests. Every single thing that we do, we use user acceptance tests before. So I'm going now to go to the Doctor on Call portals. Now, can I move ahead? Hello?
Yes, Winter, go ahead, man. Go ahead.
Okay, so I'm going now to go to that portal, web portal.
So, was it that you were on a quarantine or something like that?
I'm going to follow this link. The control, click. Okay. Now, have you gone to this? Have you got into this link? For those of you with your phone, you follow this link.
Yes. Yes.
Yes?
Yes.
Okay. You see Doctor on Call, the link? And you
Correct.
see on the right, you see the DocBot. Just scroll up at the DocBot and you see Welcome to DocBot. Has everybody seen that?
Yes, Winter, go ahead.
Okay. Now, this bot is an artificial intelligent bot, which means that it keeps learning new things every time. And what it does is that based on the questions that it asks, it generates a pre-diagnosis. And I say pre-diagnosis because the pre-diagnosis is a screening of all the patients, and this pre-diagnosis has to go to a doctor, and a doctor is going to be responsible for what? Somebody interfering? No?
Yes, Monty. Yes, Winty. I just put the thing there so everybody can see what you're talking about.
Okay. Okay. So I'm going to go through it now, and let us test for COVID. Okay?
Mm-hmm. What do you want to do? Type gender?
What?
What do you want me to do?
Go to the doc, Batman, first.
Okay.
The gender. All right?
Yes. Mm-hmm.
Okay, you want to do it? Go ahead.
Yeah, I'm doing it. Yes, yes.
All right. So you read the hi there to your free medical diagnostic screening.
Yes.
Hi there. Okay. All right. So go ahead. You're going to choose what? Male?
Yes, I did. Last time I checked.
Yes. Next. Go to the next. Next. Select your, enter your date of birth. You can enter it down the bottom, you know?
Yes, I'm doing it now.
You're doing that now?
Mm-hmm.
Go down to, it's down the bottom, you know?
Yeah, I've seen it.
Yes.
So it's right down here.
Yes.
Oh, it said it didn't recognize me?
Recognize
oh,
the time.
I know why. Yeah, I didn't see it.
See it where you put it.
Month, day, year.
You have to follow the instructions on the bot.
Yes, man.
All right, now the first bot that we did, we did voice activated. We have to take off the voice activated so that people can they made it as simple as possible. All right. So you are just Jamaican, eh?
Yes.
Okay.
Good.
All right. Enter your state or your parish. Kingston. Kingston?
Yes, I did that.
Huh?
Yes, I did that.
Okay. Yeah, and your you enter your parish?
Yes.
Next.
You don't seem to
what you're seeing, the DocBot is doing, is locating your GIS.
Mm-hmm.
So you know exactly where you are. It doesn't matter where you are, whether Jamaica or any part of the world, it will locate you. Enter your street and house. That's more specific. Right? Do you have a fever?
Yes.
Do you have a cough?
Yes.
Do you have
shortness of breath?
Shortness of breath. Okay. Next. I'm ready with my diagnosis for COVID. I just need your name and contact details. Enter your 10-digit number. Your full name first.
Yes.
Your 10-digit number. The COVID criteria determined by, okay. I can, all right, now, your symptoms are very serious and you may be infected with COVID-19. Call emergency number, right? Provide our contact. Now, if the bot doesn't leave it there, I can continue the interview and provide an enhanced diagnostic report, completely free. Do you want to continue? You know why? Because we do not only have COVID epidemic, we have 3 layers, epidemic layers in Jamaica today. The first epidemic layer, we don't know exactly what the status of it is. You know that before COVID, we had a seasonal influenza and a coryza epidemic. And we also have a chronic epidemic, a chronic non-communicable disease epidemic, which is still going on. So now, Professor, continue with your questions to see, right? Oh, you have been continuing?
Yes, yes. So I continued, and he wanted my height,
Yes.
my weight in pounds.
Yes.
He wants to know if I have diabetes. Not yet.
Okay.
Blood pressure, let's put that yes.
Yes. Do you have any
Okay.
other complaints?
I have body pains.
Headaches and body pain. Okay.
Mhm.
Has your shortness of breath lasted more than 4 weeks?
No, it's acute.
Okay. Did you feel fearful or anxious?
Yes.
Do you feel a specific object, situation, or action? Do you fear a specific object or action?
Not quite.
Do you excessively, uncontrollably, or irrationally worry about day-to-day activities?
Not yet.
Do you sometimes have ringing or buzzing in your ears?
Yes, I do. Yes, sir.
Do you have difficulty getting or maintaining an erection?
Not when I use Viagra.
Yes. All right. Have you had a nosebleed?
No.
Okay. Have you been feeling dizzy or lightheaded?
I'd say yes.
Have you had similar episodes of dizziness or lightheadedness in the past?
Yes.
Do you feel dizzy as if the room is spinning? Between vertigo and something else.
Mm-hmm.
Does the dizziness happen to get worse when you move or turn your head?
Mm-hmm. I told him yes.
Okay. Coronavirus, it said your symptoms are very serious. So so he has now made a diagnosis.
Yeah.
You may have the following conditions. Contact a medical officer, a director, right? Benign paroxysmal positional vertigo with a probability of 81.1%. High blood pressure with a probability of 29.22%. Do you want to chat with a doc?
Yes, not with a robot.
The fact of the matter is that this report is now your report. And it will come to you, right, in a report through the back end, because we have a system where that you will get that report. So you can screen 1 million patients. The fact of the matter is that this bot here is free of charge. Why it is free of charge? Because you want the patients to be able, all your patients to be able to come on board. But once the patient sees you, that is when you can charge the patient. And you use that as the data for pre-screening. Now, when you see the patient, now, that is where your other aspect of the telemedicine comes in. That is to say,
Screen, Winter.
huh?
I'm going to give you back the screen. You need back the screen?
Okay, send back the screen, yes.
All right, it's all yours.
I don't see it.
No, you would have to share it again.
Okay. Oh boy. Okay, yes, I see it. Okay. Now, I want to show you, first of all, the patients register with you, and there are some registration features and a payment process. For the doctors, there's a registration system, a payment process. Now, what we will be doing is that all of this system here at the end of 3 months will change so that you, the doctor, will control the registration, your payment features, etc. And what we have done is we have put our telemedicine doctor on call platform in such a way that you will be able not only to have people put their debit or credit cards or what have you, but also the massive amount of people who do not have any banking system, the unbanked. They can put in your portal on their financial platform, they can put money, they can save money there just in case they need to see the doctor, and you can pull it down when you do. Every doctor will in fact be responsible for setting his own fees. I strongly believe in that. Nobody should set the fees of a doctor but himself, if you are in the private sector, unless you work with government or you're in a group practice. For group practices, I'll tell you what we'll deal with in that. The portal is something that we will explain. I'll explain to you, right? But that's a little more complex. But we have here the Allied Professional Group. And this Allied Professional Group is a group which consists of these categories: guidance counselors, nutritionists, occupational health and safety officers. These occupational safety officers will be able to use this platform to deal with the questions of safety and monitoring in factories, etc. Occupational therapists, opticians, physiotherapists, psychologists, public health and environmental health officers, radiographers and imaging technicians, speech therapists. So these also, there is a model that we have developed for this category. So therefore, if in your big or large business, medical business, you see the need to have a nutritionist, then the nutritionist would be able to use that platform to see the patients within your jurisdiction, within your portal. Or outside, you don't have to only deal with your portal. Now, we also have patients that, let's see, we have some updates to come. And these are exciting updates. We have doctor on call for nursing, doctor on call for remote testing of blood pressure, right? For e-pharmacy platform for the pharmacists, and of course, the institutions, corporate medical practices, private group of practices, etc., etc., etc. And of course, the bot, which we already have, which is what you have been using. And so this is the most comprehensive and sophisticated platform for telemedicine. And believe it or not, it does not cost you a cent. You know why? Because your colleague and his partner were dedicated to use what we call sweat equity and a lot of studying for 17 years to pull all of these disparate components together to develop a platform that is truly exciting. At this particular point, we have said, look, if the government wants to use the bot to do mass screening for COVID, it can use it, it's free. We will show them how to develop the back end, in other words, and we will show them, we will develop what you call the data from it and make it available to them. Data having to do with not only the high risk for COVID, which they then can select and test those persons, but also the data from COVID. We know where the patients are located, we know what their name is, etc. So we can plot, they can plot that. A mapping, you know, mapping is an essential part of epidemiology. Surveillance, tracking and tracing, because we can deal with it more over and over again. Added to that, big firms can use it to screen their staff and say, no, you are at risk, you better stay home. No, you have it, go straight to the doctor or go find it. And so therefore you are able to catch up. Right now, I'm afraid that our surveillance and tracking and tracing system is behind the ball. It's certainly not ahead of it. And you cannot, and you don't have the resources to test everybody. So by using the DocBot, which is part of the telemedicine, and it's free of charge, they can in fact see millions of people every day. The DocBot can, we can, what we call white label the bot. So the bot coming into your portal will be leave his bot, leave his DocBot, or unusual DocBot. And she can use this DocBot when she's sleeping. And by the next morning, she will get all these reports and now know how to follow. And she charges her own fees for whatever. I'm not going into the details of the system as to how we deal with you can set your appointments, and we can make the DocBot set your appointments. And there is also, we are going to use the DocBot to do surveys and research and to get all your data together and to give you a report every week as to how many patients you have, what's the epidemiological pattern, what's the outcome of your treatment, so that you are able to analyze and evaluate yourself using the DocBot. But that, of course, is another matter, which I will explain. And now is not the platform, the time to do that. But for telemedicine to work, and for you to have your own portal and to get it working, it means that you have to use artificial intelligence to enhance your quality of service. What we do know is that the artificial intelligence that you have there will be more or less geared towards your practice and be able to deal with your practice and your patients and your evaluation and your research and your whatever, right? And there are many, many functions that we can make the DocBot do because it's just starting. But if the government doesn't want to use the DocBot, then fine. But guess what? We know that as doctors, we have come under a lot of pressure because this technology is technology which is the cheapest. And you don't have to buy anything, and it is free to the doctors. Now, how do we, and incidentally, in your own portal, you can do what you want in your own portal because you will have your own website. If you want to advertise anything on your website, that's your business. We're not concerned about that. So how does Doctor on Call get paid? We get paid not by splitting the fees of the doctor, but we say, depending on the scale of the particular enterprise, we will charge anything between 5% to 15%. If there's a one doctor, we're not charging it out of the doctor's fees. We're saying whatever the doctor charges, he puts a charge of 5% on top of that, because we have to pay the bank whatever we make 4%. So, and we also have to pay Microsoft Azure. We have to pay about 6 other infrastructures that we have put together in order to be able to come up with this platform. No technology in today's world do not pay others for their platform. And so we have to pay. Okay, so at this particular point, I'm going to stop and take questions. Hello?
Yes, Winter, thanks so much for your presentation. Just some housekeeping rules for those of you who want to direct a question. If you clicked on the participant button, you'll see the ability to raise your hands, and then we'll go based on that. All right, so I'm seeing Dr. Pauline Williams-Green raising her hand. Go ahead.
Hi, good night. Thank you so much. Very interesting talk. My question is in terms of the legal and ethical ramifications,
okay,
or is it privacy? Not quite sure. The privacy issues.
Okay, okay. All right. Now, this particular issue is one which we have taken rigorous care about. And not only have we put in place, if you look at the link, you will see https:// then www. Then you have the name.com. The https:// it is the indication of the best form that we know to date for security. It's a hypertext security, and that is what the standard that we have. Now, the other standards is that where is it stored? And it's stored in the cloud. And that is where we have the highest form of, in fact, security. So your data is stored in the cloud. It is your data. You have access to it. But the patient also has the right to get that data. And the only other person who can get that data is if it comes by court order. And so we have tightened up on that. And it is something that has always been our concern from the beginning. So it is an integral part of our standard.
All right, thank you, Dr. Davidson, for that. Dr. Ratcher, your hand is up.
Yes, Prof, thanks. Winty, a
Yes.
fantastic presentation, sir. Beyond fantastic. I'm bowled over. I have just one question, though.
Yes.
Many of my patients use insurance, health insurance, to pay me. How does it work with the system?
All right. Let me tell you what the health insurance system is going on now. I have a lot of friends in the health insurance industry, and they have one system where they pay one broker and they use a particular system. And the system that they use is a swipe card system. This system will not only give them a lower cost, but it's a system which will improve their bottom line much more than the system that they have. Added to that, they can get new products because of the nature of the qualitative height of the telemedicine system. Remember, it is totally web-based. You don't have to go through a middleman. So any insurance company who seizes this opportunity with the doctors will find that they will have massive amount of products, and that, in fact, the people who will access it are not only the people who have a 9 to 5, but especially those persons who are in small business, and also those persons who do not have a bank account, the unbanked. That is where you have a massive amount of persons. They must understand that right now the insurance companies only have about 20%. They can have up to 80, 90% if they come with the system for the unbanked. But it's just that they don't know, and they think they are wedded to a particular system that is too expensive. Our system, your system, and our system is the best. Believe you me, I know all the systems in the world. I teach about them.
Dr. Vassar?
Good evening, are you hearing me?
Good evening.
Hi, thank you for a wonderful presentation, Professor. I really love this platform. A colleague who resides in Canada, she's current with her MCJ registration, and she was wondering how something like this can affect her in terms of her ability to practice in Jamaica.
She can use it so long as she has MCJ. She can come on the platform unless she's registered.
All right.
She can use it. She can use the platform. She'll be able to use the platform because we can create a portal for her in Canada, right, and she can see the Indian population as far as the North Pole.
Oh, so even though, right? So even though writing scripts.
Yes. We can write with the, all right, now, in relation to the scripts, right, we are, the way that we have structured our what you call it?
Platform.
Prescriptions. It satisfies the highest standards from the American Telemedicine Association. I'm a member of the American Telemedicine Association.
Oh,
and it is designed with every single detail, right? Okay, right. And as a matter of fact, it is more legal than anything else. But the pharmacists, I don't know why they want us to go put on WhatsApp. WhatsApp? Oh, could you put something on WhatsApp?
Yes, I agree with you completely.
I've made a presentation to the pharmacists, and I demonstrated that to them. They said they said they don't want to have any e-prescription.
Oh.
I wanted to put a WhatsApp as if WhatsApp is not e-prescription.
Right, this is a similar form, and even
yeah, but they have a problem.
Less secure.
I have to come around to it. You don't worry about that.
Okay. My final question is regarding the unbanked patient, and you
Yes.
mentioned that they could save money on
their account. Yes.
Yes. Does that
Just
mean
like, for example, let us look at the cell phone.
Right.
Don't they top up?
Yes.
Well, they can top up too on their account and doctor on call.
Okay.
Yes.
Well, I'm not sure I understand it fully, but thank
when
you.
When you look at the details, because we would have to go through some little detail and training. But the fact of the matter is this, that why we are taking 3 months to do it is because we are upgrading,
right?
And we are putting where doctor on call doesn't want to participate in the doctor's space.
Okay.
So it comes on the platform, we're upgrading, but we have to give training. You understand?
Yes, I do.
But it is easy to do. All you need is a little practice, like everything else.
Okay. Thank you. I appreciate this very much. It's very encouraging. Thank you so much for all your hard work and efforts.
All right, Dr. Lee, you're next. Michelle?
Hear me now?
Yes, Michelle, go ahead.
Okay, one of the things I think that we need to lobby about is the prescription. The pharmacy council says that they need a hard copy of the prescription within 72 hours. So they're not only accepting WhatsApp. After the WhatsApp, the pharmacists insist, and I think the medical council sent out a letter stating that they still want the hard copy of the prescriptions. And I think they want the hard copy, that the pharmacist within 72 hours needs to have a written copy, not WhatsApp, not email. And I think now with the telemedicine, that we as a group, we need to lobby for this. In the States, go ahead.
All right, it's a great question. The fact of the matter is this, that I happen to be the chairman of the Medical Facilities Committee from the Bureau of Standards. I can tell you that we are now dealing with standards, and we are integrating all the standards that we have done so far in relation to the whole of the medical profession are standards which are global standards. And once we have global standards, it means that we have a platform to do this. And so we are now I have put on the platform, on the agenda for telemedicine standards. And so therefore, we have no legislation right now, no standards at all. And once we put these standards as part of the regulations, which is going to come as quickly as possible.
Okay, so you're in the process because
we're in the process of doing this, yes.
I wrote to the medical council, and the medical council sent an email from the pharmaceutical council last month saying that they still are demanding the hard copy. And I do think we need to change. In the States, most prescriptions are sent electronically. It's very rare that somebody actually uses a hard copy.
There is no legislation. There is no legislation in place. But the fact of the matter is that if there's no legislation in place, right, then you have what you call a blind situation. And under this blind situation, you are perfectly free to do what you can. Nobody can sue you.
Well, I'm not sure about that, because that's not what the pharmacy council is saying.
The pharmacy council has its axe to grind where that is concerned, but we'll get that done within maybe 2 to 3 months.
Okay, and I think one of the things we need to mention, which the other caller was talking about, if she can practice from Canada, one of the big things that we have to mention is the malpractice insurance. So you have to remember that
we already have that. So what I think we should do, and I've discussed this with Dr.
MAGIF is not, sorry, Dr. MAGIF is not covering for telemedicine. MPS said they cover.
Not yet.
Right. So that's a major thing, and MPS. So somebody from Canada, and one of the things with MPS is that you're not supposed to practice out of your jurisdiction. So somebody from Canada literally they can potentially get sued for seeing patients in Jamaica if this is not their primary.
No, well, the thing about it is this, that
believe you me, so that is another thing that needs to be covered. We need to change.
Yes, believe you me, with COVID, it's not going to be normal anymore. everybody's going to move towards telemedicine.
But how are we going to get MAGIF? Because I wrote to MAGIF also to say
MAGIF
to
is
ask
not
them to
controlled by MAGIF, you know, it's controlled by the doctors.
Right. So we as the doctors
we have been in discussions with them for a few years, right? And as soon as we are ready and they can work out the insurance coverage, right? And we have it legal, there's nothing.
Hello.
Yes, there's nothing that ought to be an obstacle for us.
So have you formally written to MAGIF to ask them about the telemedicine insurance?
No, I've discussed it with Dr. Lockhart.
And so what's going to happen from there?
He seems open to it, so long as it is financially
but that's the same
viable.
thing he told me. But I mean, we need something objective and something
Yeah,
real to happen.
well, this is what we can only do. What we can only act. What in the areas that we have control over. Now we have control over our standards. That is where we start.
Okay. All righty. Thank you.
Yes.
Dr. Asnani.
Hi, evening. Good evening, Professor Davidson. Thanks so much for that. Part of my query was what Michelle just spoke about, but before that, I'm not sure if I missed it. I dropped off for a minute. Is there any verification process for a doctor or a practice who wishes to create their portal on this? And part of that would, of course, include what kind of legal coverage they might have. But we spoke about that, MAGIF and MPS and stuff. But do you verify, or will this Doctor on Call Jamaica verify people who are seeking to register with this service?
Look, the fact is, every doctor has the right to register on this platform so long as he has paid his dues to the medical council. And there will be no restriction for any doctor having his own portal, because the basis on which we set up this platform now wasn't so up to now, right? But the change is that every doctor will have his own web portal to do whatever he wishes, build his website, put in what he needs, etc. And he will also have his artificial intelligence, and that is going to be exciting. I can tell you that.
Mm-hmm, mm-hmm. Yeah, I mean, I'm not fully understanding the process yet, and I guess it'll take.
Well, what you can do, you
Mm-hmm.
can play with the bot, you know.
Right.
Right, and you have the URL for it, so you can play with it.
But how will anybody know that I'm Monica Asnani and not Marvin Reed?
That you.
If I decide to.
Well, the fact of the matter is this: if you want to lie to the bot, then you can lie. But the fact of the matter is this: that you know, the fact is that you can test the bot. The bot knows when you're lying to, you know, because sometimes it carry around and it asks you the same question again and over and over. It does a lot of other tricks.
But you know, like in our offices, we are expected to display our licenses in if we are employed to a practice.
You can't come on the platform unless you're registered with the medical council. You can't.
Right. So that's what I was asking. If there's a verification process.
Yes, man. Medical council. Yes, man. Yeah, man. We have the whole database there.
Okay. I've got to try it. Thank you.
Yes.
Thanks.
Dr. Antoine, you're next.
Good evening to the audience. Good evening to
Good evening.
Davidson. Thank you for the presentation. I wanted to know, does your presence on the portal, is it limited by presence on other web portals?
No. As a matter of fact, what my partner and I said, look, you will find some doctors, you know, who will make some other arrangements in terms of the money that they collect. You know? And I said to my partner, and we agreed, Well, if they say they don't collect the money, that is their business. I don't business with that. I'm not going to run after the doctor to see exactly whether they collect or not.
All right,
Because
thank you.
if they don't use our banking system through NCB, and NCB is our bank, okay?
Okay.
Right? If they don't want to use our banking system, then that's it. But we have to use our banking system because we are a global platform.
Okay, Prof.
Once you're on that
Davidson.
platform with that portal, you go global. You go into the Caribbean, you go to Africa, you go anywhere. So long as there is reciprocal recognition of our respective doctors. And I can tell you something, it will be in the interest of the government to negotiate with countries in Africa so that our doctors can see those patients there too.
Thank you, Prof.
Dr. Harper Smith, you're next.
Okay, good evening. Thank you for that presentation, Prof. I'm not sure if I missed it, but I was wondering, would we be able to record the telemedicine visit or type some notes on each patient's file within the website?
Okay. Well, the fact is that myself and my partner again discussed this last night because the model that we have developed is that separate and apart from the interactive encounter, which is a video conferencing encounter, we will have all of that encounter recorded. But we also had built into the system some notes. So Sanjeev said, boy, you know, I don't want to make it so complicated again, you know, Prof. Right? I said, but listen, we doctors make notes, you know, right? So he said, I said, I must insist that separate and apart from the video recording, we want to retain that those notepads that we have there too, where we can also write some notes there, right? But eventually, the voice recognition and all that sort of thing, where you are able to dictate, is going to supersede the notes. So he said, but they're going to transition to complete voice and video, right? Right? Because all of that is stored. I mean, we can store massive things with terabits on the cloud. You don't have to worry about that anymore, right?
Okay, so
it's
then
a voice activated system, right? And so therefore, you can voice the thing and the voicing, you voice it and you have a voice to text. Voice to text is easier than text to voice. All of that will be part of it in the next 3 months.
Okay, thanks.
Dr. O?
Joined the Zoom meeting around about 6:35, and I realized that there is no, and then I do some other things, and I'm like an hour late. When I start, I just want to know, is that an application or a web page? That is number one question. And if it is application, it can be getting in both Google Play Store and Apple Store, both of them.
First of all, if you look on the website, you will see. Just go through the website. It is at pause now, right? Right. It is not active now, but it is there for you to go through it and to see exactly, to look at the terms and conditions. All of these terms and conditions and medical legal things are written there. It will be also translated on your portal. Everything that you see that is used on here, once the service is here, it will be on your portal.
Okay, can you just please kindly tell me the website address again, please? I was late. I'm so sorry for you to repeating again, though.
HTTPS.
Yes.
Colon.
Yes.
Double backspace.
Yes.
www.3w.
Yes, 3W.
Doctor on Call.
Doctor
Spell it
on
out.
Call. Yes, yes.
Jamaica.com.
Jamaica, JAMAICA.com. Okay.
That is the URL. Yes, that is the URL.
Yes,
but
okay.
Right now, we are upgrading. We're upgrading now to commercial. There is one particular area, and it's a term that I have coined, because as you know, when you pioneer anything, you coin the phrase. I call it med-commerce.
Okay.
I call it med-commerce. You'll be able to do a lot of med-commerce on your web page.
Okay. And another thing is you answer like even patient from United States, you are in Jamaica, you can see. But the thing is, so it not make sense for doctors like have to go and do USMLE. That is my question. Is the US really gonna be accepted who is not passing through USMLE exam? That's the thing.
Let me tell you this.
Mm-hmm.
When we finish with the standards from the Bureau,
yes,
this platform will be of the highest standard. The Bureau of Standards will record this as because I know all the standards, and I can, if you want another lecture on that, I can give you. But that's that's another thing. That's another matter. Right? Because you have HL7, you have HIPAA compliance, you have a whole host of different standards. Okay? All right? And all these standards are already embedded in our Doctor on Call platform as it is now. And this will be carried over and will be part of the standards that will be put in there. So therefore, nobody can come with any fly-by-night foolishness to fool doctors.
Okay. All right. Thank you so much.
Dr. Morgan?
Hello?
Yes, You had a question, huh?
Oh, all right, you're hearing me now?
Yes.
Right, so.
Who is that, Anna?
Yes, it's me.
How are you? How is everything, my dear?
I am holding on, you know. This is COVID times, but we take it a day at a time.
Yes. You better duck.
Yes, my dear. I just wanted to ask a little bit about the prescriptions, Winty. I mean, I see how we can make this work locally and maybe even in the English-speaking Caribbean area.
Yes.
But in terms of actually helping a patient over, you know, in Africa or in Europe with a prescription, and also with an English prescription where they don't even speak the language.
Okay.
And also the laws over there have to accommodate us doing this. So that part seems to be like a big thing to come.
Very important point. All right, let me tell you how I mean, this is something that we've been tracking for the past 10 years. Believe you me, it's as long as that. First of all, even though the internet has broken down every single national border, and people, once you're on the internet, you're global. Yet, our jurisdictions, from a professional standpoint, are not global. And they're not global because of standards. And the way to go global is to have what we call globally acceptable standards. And that is where you have this, you can speak the same language with anybody, anywhere and everywhere. And that is why the Bureau of Standards is such an important institution in this country. Because what we are doing now in relation to the health sector is we are adopting and adapting standards of best practice standards throughout the world and making our Bureau a best practice Bureau as far as standards are concerned. And I can guarantee you that when we come out with those telemedicine standards in a few months, those standards will also be best practice. Now, even after you have best practice standards, there is a barrier to this because of the professional barrier. Every profession puts a fence around itself, and every nation puts a fence around itself in relation to its profession. But this is what I've found. All my family is in the United States. And when they want when they have a problem, they call me and we go through it. And if I think it's something that I could give a prescription, I send a prescription to them by email, and they call their doctor, and their doctor calls me, and we discuss it, and he gives them a prescription. I think the time is going to come when we're going to start to recognize our prescriptions. It is inevitable. You can't stop the march of technology. That's my view.
Hoping that won't be too far from now.
No, it's not too far from now. COVID is going to do it. Believe you me.
What? Share content.
Yeah, might do quite a lot, yes. Okay, well, we
it's a new normal now, darling. A new normal. So you better get ahead of the curve.
Okay, listening, Minty, listening.
Yes.
Thank you.
Yes.
All right, colleagues, it's now 8:26. We will continue roughly until about 8:30, so we'll have some more time for a few more questions.
Well, it seems as if I've been very clear.
Someone waving their hand on screen look like they're asking a question if you see the picture.
Yeah, all right, so right now I have Dr. Levy, hands up. Dr. Levy, go ahead, please.
Good night, Marvin. Good night, Winter. Thank you for a wonderful presentation again.
Yes.
I was trying to ask you to speak to the audience and tell them again how to indicate that they want to ask a question, because I think Dr. Eve wants to ask a question, but she is not recognizing that she has to go to the participants and click on the hand thing. So probably you could tell us that again, but most of the questions that I had have been answered. My only, I'm just waiting for this for the next few months for this thing to become, for Prof. Davidson.
And I'll keep the family, I'll keep you, because one of the things is that we have to have user acceptance tests.
Okay.
You know what I'm saying? Especially with the new design. Basically, what we're doing is we're building a massive platform so that it can take a massive amount globally. You understand?
Yes.
In other words, yes.
Okay.
And we have the capacity to do it.
Okay.
No.
All right, Dr. Gordon Donald, President of the Association of General Practitioners. Donald, go ahead.
Say a hand here. Press the hand.
Where's mine? Okay.
Press the hand. Press it already.
Are you hearing me?
Yes,
Donald, go ahead.
Hi, Prof. Excellent presentation.
Yes.
How do you see telemedicine affecting training the medical curriculum?
Well, the fact of the matter is this, that Professor Figueroa invited me to give a lecture to his, I think his doctorate students, right? And I think, well, when I was at the university, I was a fellow in the graduate school and put on some very good telemedicine exhibitions, etc., etc. Everybody at that time were saying, boy, it's very good, you know, but it's ahead of its time. Well, that was some time ago. That was about 11 years ago. The fact of the matter is that its time has come. You can't stop it. If you try to stop it, you're going to marginalize yourself. And I think that it is an exciting period because we are going to have, there's a number of doctors who are also engaged in developing this technology. But believe you me, it's not easy. It's not easy. It's not easy at all, especially when you are in the pioneering area. Because I have had to, if I tell you my experiences, boy, you would think that Sanjeev and myself are two idiots. But we are committed to it, and it is happening. It will happen even greater. And now the time has come. And I'm only concerned that the government who don't really have any money, right? I'm a public health person. I know what it is to deal with surveillance and tracking and tracing. And it's a bot that can do a lot of surveillance and, well, tracking and tracing, and also pre-diagnosis. And we will show them exactly how they can incorporate it in doing some of the tracking and tracing that they have now out in the communities, because I can tell you the community spread is going to be explosive.
All right, Dr. Seni Onanoshu.
Okay.
Dr. Onanoshu.
Once the presentation, Winty, was excellent. Yes. However, we had all the goodies of telemedicine. What do you think about patients? Some patients feel that they still want the doctor to touch them. What do you think about that?
That's fine.
But telemedicine, you don't have that human to human.
On the telemedicine platform.
How you call it?
In each doctor's portal.
Patient
themselves, there is.
They just see you at a distance.
Yeah, there in each patient's in each doctor's portal.
Yeah.
There is a diary, and the patient can make the appointment in that diary. All the doctor has to do is to put is to put in that portal. It's given. In other words, the diary is so easy. So the doctor can say when he will be there, when he will not be there, and when he has appointments available. And they can come in to see him. They can not only make online to see him by telemedicine, but if they want to see him in his office diary is there.
Okay.
Okay, thank you. Dr.
Thank you very much. Thank you.
All right,
in other words, the doctor can work from his home. especially female doctors who may be pregnant. And with physical distancing, it is the greatest.
Dr. Eve, I'm seeing here Dr. Eve. Go ahead.
Yes. Hello, Wincy. Excellent presentation.
Yes.
But I noticed you didn't mention anything about pediatrics.
Well, the pediatricians are there also. And if you look in the terms and conditions, we have the terms and conditions there for the pediatricians too. It's embedded in it.
Okay.
Yes.
Excellent presentation, though.
Yes, darling.
Dr. Harper Smith, again, go ahead.
Hello again. Two questions. Is in the registration process for the patient, do they sign some form of consent or give some form of consent?
Yes. Yes.
Okay.
Look, I teach medical ethics to well, I mean, it has to do with research, but the fact of the matter is this, that the consent and protecting people's rights are things that I don't take lightly, right? That is part of the responsibility of our profession, and all of us as professionals. And so therefore, I don't take that lightly. It is built into the system. It will never compromise that. And especially with minors, right? With the pediatricians, etc., and the children, it is very, very important. And so it is also taken into account. You should read the terms and conditions because it is really comprehensive.
Okay, thanks. And then also, will they have the ability to upload results so that you could review them?
Yes, man. Yeah, man. We have, as I said, all the standards. We have the standards for laboratory, standard for radars. We will roll out those things. We don't want to roll out everything at the same time because that is what we have in this particular version, the version that's on pause now, right? But because we have the artificial intelligence things, etc., we want to make sure that at every step of the way we have the stability, right? We have the reliability, right? And we have the confidence. And we gradually roll it out and have updates as we go along. Give you updates.
Okay, thank you, Prof.
And if the profession feels that we should put out this particular update earlier than this particular update, you just let us know. Let me know, right?
All right. There are two final questions. So Dr. Buchanan, then followed by Dr. Gabidon, and then that will be it for the questions. Dr. Buchanan, go ahead.
Yes, I'd like to know if the platform will be able to use digital tools on it, for patients who would like to, for example, use scopes, otoscope, stethoscope, and things like that.
Let me tell you, that's the whole purpose.
Okay.
Hopefully I can integrate 5G in it too.
Okay.
I'm talking ahead of myself. All right. Let us get to the end of the 3 months and then move from there. But 5G is part of it. It's going to be part of it.
Yeah. So I mean, if you want
all the different tools, anything that is mobile, anything that's mobile can be integrated. So long as we put it's Bluetooth. It's Bluetooth.
Yes. Okay. Great. Thank you.
All right, Dr. Gabidon, you are the vintage wine.
Okay. Thanks. Good night, everyone. And thanks, Prof, for your very comprehensive overview. In terms of I think I missed that part. Did you say 4% was a fee? And you also
No. I said, because we have to go through the banking system, we go through the banking system, right?
Yes.
And let me spend just 3 or 4 minutes on this. We started building our transaction resolution system using PayPal. And when we use PayPal, our user acceptance tests, PayPal paid us, we're able to pay within 2 days. And gradually, we found that it went from 2 days to 2 weeks to a month to 3 months to 90 days. When we would ask PayPal, why is it that we're 90 days? They said that they are checking for money laundering. I said, to hell with you. So we came to Jamaica. And we said, all right, let us see if we can deal with one of the banks here. When we went to find out if the banks had a system that could integrate with a web-based system, none of the banks said no. So we went to NCB. And NCB said, yes, they could integrate. I said, all right, we'll build whatever patches you need and we'll try and do it. So we started building some patches with them, only to find that they were unable to do it. So we said, but you must be able to do it. You are a big bank and what have you, right? Let us work together. So they said, boy, we have to call our principals abroad. So I said, okay, let's conference them. So the conference, this big bank abroad, I'm not sure if it's Bank of America or Bank of this or what have you. But we said, look, you have this facility where we can get automatic payments on mobile automatic payments. He said, yes, we do it in the United States. I said, but this is a medical facility, it's a medical platform. Let us, yeah, I mean, why can't it be done by NCB? You know, the guy said, it can only be done in the United States. We have not given that resource to Jamaica yet. Now, you see the unfairity in the inverted commas. Anyway, we persist, and I think that we have some solutions, right? But the fact is that I refuse to proceed with a system that does not take into consideration the unbanked. I refuse. And this is because I mean, we have the system in place for anybody who has a card, but I refuse to go ahead with it. You know why? All the sacrifices that are made by the doctors, etc., must redound to poor people in this in Jamaica getting the service from the doctors at the lowest possible cost. Because all the surveys that we did among doctors, and we did quite a number of you know, survey monkey and all that sort of thing, and we have all that results to show. 80% of the doctors say that they would take, if they do telemedicine, they would take a pay of less than half the pay of the patient coming in to see them in their office. And I thought that I mean, it gave me such a good feeling about my colleagues, right? Because number one, you can do it from the beach, you can do it from your bathroom, you can do it from anywhere. You don't have to have no overheads, you don't have nothing. And especially for those doctors who are going to retire, right? It is very, very good for them. And it costs them less. So let the patient, I think that using the telemedicine platform, we can have universal access to healthcare. And it will only redound to a greater standard of healthcare delivery in this country. And I think that we doctors must, we have the opportunity now to take leadership in that. You can't wait on nobody else. No other profession you can wait on. We have to do it.
Okay, thanks, Prof. But maybe I missed that. So when the patient pays,
yes.
You set your own fees, and you said there's no fee sharing. So
no splitting, fee splitting.
So it's a separate fee for the
platform. Platform. The platform will, say for example, you set a fee of $100.
Yeah.
Okay? Then you get your fee of $100. But 10% is put on top of that. So it's 110.
Oh. So the patient pays the fee.
The patient pays that, yes.
Right. Okay, thank you very much. Okay,
so we don't take anything from you.
Okay, thanks.
Yes.
That's clear.
All right, colleagues, I think we've had a very good and robust discussion. I don't like to leave anyone unsatisfied, so I'm seeing a Galaxy A20. Could you just identify yourself and then proceed and ask your question?
Hello, everybody. Good evening. My name is Dr. Greaves. Are you hearing me?
Yes, sure. I know Dr. Greaves.
No, this is Cecile Greaves. I'm not sure if you're familiar. Everybody knows of Venslow.
Okay.
All right. So I'm a general practitioner. I entered the meeting a bit late, but I'm quite curious as it concerns this platform clearly would not have emerged if it wasn't for patients. You know, so patients are at the basis of all of what we're discussing now.
Yes.
My question really is just, I would imagine that just as patients become savvy using the telemedicine platform,
yes.
that persons, you know, we have the patients who are they like to almost doctor shop. So some of them would see a doctor and they feel as if they're not satisfied. They need a second opinion.
Yes.
I heard briefly the comment about these, what I call it now, your consultations being recorded, but how will it prove useful to another doctor on the platform to access?
Referral system. Just like, for example, you have seen a patient. The patient is yours. The patient goes and see another doctor, right? The person can either go and see another doctor on its own, on his or her own, or they can be referred. Every general practitioner, every family physician refers patients. And when you refer them, you send the notes.
Okay.
And you send the notes to them. And this is what we have, right? Say, for example, you were referring to a hospital, and a hospital has a different electronic medical record system, right? So long as the hospital has as what is called the API, the application program interface, we can integrate the telemedicine notes into the notes of the patient in that hospital.
So I wasn't thinking about a referral system though, you know, Doc. I would imagine that referrals are possible, but I'm thinking about the patient who, say, comes to me and they have an issue with the consultation, but they want to see, say, another GP on the same platform. How then will they be able to access?
Well, they can go to the next GP's portal. They can see another GP. Every GP that's on it has its own portal.
Right, but
we have a list of telemedicine have a list of all the portals.
So each doctor is able to access patient information even though they did not see that.
They can't access the information without permission of the doctor.
Okay.
Remember, you know, the doctor owns the information. The patient has access to it. That's it.
Okay. All right. Thank you.
All right, ladies, colleagues.
Right of access to it.
Right. Colleagues, thank you so much for your participation. At this time, I'm going to hand over to the moderator, Dr. Levy, for us to do the wrapping up process.
Thanks, Marvin. Are you hearing me?
Yeah, sure.
Wonderful. Thank you, first of all, Marvin, for hosting this meeting. Professor Marvin Reed, who is the president of the Caribbean College, wearing so many hats and being so helpful to us in the local chapter in so many different ways. Thank you, sir, for hosting this rather wonderful meeting. And of course, to our chapter president, Dr. Ananuju, who gave us the welcome. And to the evening's star presenter, Professor Winston Davidson, sir. All I've said, and all those who have not gotten a chance to say, have indicated how thankful they are for this presentation, which has opened a lot of eyes and, of course, opened us to a lot of possibilities and the future of medicine. We thank you, sir, for a wonderful presentation, and we pray that the Lord will continue to give you strength and, of course, the wisdom and knowledge and the courage to go on to complete the phases that will just enhance this platform over the next 3 months. On behalf of the Caribbean College of Family Physicians, I also want to thank the participants for their interest. I noticed we had at the maximum level 117 participants, and I think this kind of interface, this kind of platform that we're using has helped us to enhance the participation, and of course will be the wave of the future as well. So all in all, I want to thank everybody for making this evening a rather wonderful evening, a rather informative evening, a rather rewarding evening, and I look forward to our involvement, continued involvement, not only in this, but in lobbying for some of the participants indicated that we need to form, well, not exactly form a lobby group, but we need to lobby for the changes that need to be done at the MAJIF level, sorry, and also at the Pharmaceutical Society level, because everybody needs to come up to par and to understand, and also at the insurance providers level as well. All of us need to come to the table because our patients at this point in time need us but they are afraid of coming to our offices. And so, sir, I want to thank you for allowing us to be a part of this discussion and giving us all of this encouragement and this information to know that there's hope for a brighter future, because our practices have taken a severe hit, and all of us have felt it. The numbers have dropped, I would say conservatively, at about 50%, because patients are just afraid of coming to the office. And this is a way where we can reach our patients can reach us safely. So once again, sir, I just want to thank you for a wonderful presentation, and I'm thanking you on behalf of the Caribbean College of Family Physicians, the Jamaican chapter. Thanks to all the participants, and thanks again to Prof. Reed. And have a wonderful night. Good night to you all.
Thank you very much for the invitation.
Thank you, sir. You're welcome. So Marvin, that's it?
Yes, that's it. I'm going to end the meeting now.
Okay, wonderful. Thanks again, Marvin.
Thanks, Marvin.